Absolutely, absolutely. So hi, everyone. My name is Rita K. I'm president of the Institute for Safe Medication Practices, and most people call us as ISMP. And before I start, I was just say that, oh, and by the way, I'm a pharmacist by training, but I've been working throughout my clinical years with lots of anesthesiologists and had definitely enjoyed working in the perioperative space. But before I start, I just thought, for those of you who might not be as familiar with the Institute for Safe Medication Practices, I will give you a two-liner of what we do. We are the only 501c3 nonprofit organization that is completely devoting to preventing medication errors. And we do our work by really running our medication error reporting program. We have practitioners, like a lot of you sitting here, voluntarily reporting medication errors to us. So we run this national medication error reporting program where we will collect this information and we analyze them. And unlike a lot of medication error reporting programs, we actually go out and reach out to our reporters to try to get some more information to understand the root causes of the problem. And with that, and information we got could be actual errors that happen, but a lot of times it's also near misses that happens that was reported to us. And we disseminate these information with risk reduction tools and error prevention strategies through our newsletter. We also put together guidelines and best practices to prevent medication errors. And the ones that I'm going to be talking to you about today is the ISMP guidelines for safe medication use in the perioperative and procedural settings. So by way of background, ISMP received a grant from funding from the US Food and Drug Administration, and the study period was between 2019 and 2022. And the goal was to identify and quantify the current state of perioperative medication safety practices in US hospitals and ambulatory surgical centers. We first assembled a multidisciplinary advisory panel consisting of anesthesiologists like yourself and certified nurse anesthetists and perioperative nurses and pharmacists, as well as medication safety experts to develop the ISMP medication safety self-assessment for perioperative setting. And the assessment was released nationally in 2021 and closed in early 2022. And in 326 hospitals and 60 ASCs provided their data during this period. And from this information, we identify safety gaps, and this also informed the discussion of a national summit that Nat was talking about. So in November of 2021, ISMP hosted the Consensus Building National Summit titled The Future of Perioperative Medication Safety, Charting Our Path Forward. And I would ask in the audience, if you can raise your hand if you have participated in this conference. I know that there's quite a few of you. Thank you very much. Cool. Awesome. So as you can see, we have invited clinical experts, anesthesiologists, CRNAs, OR nurses, pharmacists, and also representations from professional organizations. I have to give a shout out to this organization. APSF actually not only participated in our summit, but also sponsored the summit. Other organizations, professional organizations such as the Association of Perioperative Registered Nurses and a lot of others have participated. Government agencies such as the US Food and Drug Administration has participated, and accreditation agencies like the Joint Commission, as well as quality and safety organizations such as the IHI and the ASC Quality Collaboration. And most importantly, we've also included the, industry leaders, because we know that we can't solve our problems without our industry collaboration. So the focus of the summit is to explore the current barriers to adoption of known medication safety practices and identify future opportunities to limit the risk and advanced safety in this setting. And from that, we drafted the ISMP guidelines for safe medication use in the perioperative and procedural settings. And we have recommendations in 10 key elements. And what I'm going to discuss with you today is a few of these elements that is highlighted in blue. But before we start, I just thought I would share a case with you. And this is actually a recent case that was reported to us about 2 months ago. Here we have a 55-year-old with a history of hypertrophic cardiomyopathy with permanent atrial fibrillation, status post Watchman device placement, was presented for a 1-month follow-up for a transesophageal echocardiogram. The procedure was performed under general anesthesia with a natural airway. A CRNA removed what they thought was a vial of lidocaine 1%, which is 15 milligrams per 5 ml injection from an open matrix draw of an anesthesia cart, which is a common setting in the cath lab. And went ahead and prepared this thought to be 15 milligram dose of lidocaine in a syringe and administered to the patient. Shortly after, the patient became apneic, so the procedure was paused and the patient was bagged. The team then discussed potential causes for the unexpected apnea and found that instead of lidocaine, the patient actually inadvertently received rocuronium 15 milligrams per 5 ml. At that time, Sugammadex was administered for reversal of this neuromuscular blockade, and the apnea subsided. And the patient went on to complete the procedure and recovered from the procedure without any incidents. Now, you can see in the bottom of my slide, the lidocaine and rocuronium injections were both supplied in a 50 milligrams per ml vials with a blue cap. And unfortunately, they were stored right next to each other in the anesthesia cart. So the CRNA relied on visual cues, the cap color, and the storage location to identify what they thought was lidocaine, but unknowingly administered rocuronium to the patient. I would pause and ask you to think about how many times did you reach out to the storage location using the visual cue of maybe a cap color to pull a medication and forgot to validate that that's the actual medication. That is actually the medication that you're looking for. So hence, because wrong medication administered to patients because of syringe swap or wrong clinical decisions in the selection of medication is the #1 cause of medication error in the perioperative area, we recommend that drug labeling, under the drug labeling and packaging and nomenclature section, that readable labels that clearly identify the drugs on all drug containers in the perioperative setting, and the drugs remain labeled up to the point of actual drug administration. And some of the details of these recommendations actually included a very audacious goal of eliminating handwritten labels and including machine-readable code on labels by 2025. Now, we purposely call it machine-readable code because we know that technology is evolving, and besides barcode scanning, there's other technology like RFID that could be used in the future, and hence, we really wanted to make sure that we eliminate these handwritten labels and have machine-readable coding on these labels. While I know that 2025 is a few months, it's coming up in a few months, I know that not everybody can be implementing this goal. I'm hoping that with this audience, you can help us accelerate this implementation of this goal, and maybe by the end of 2025, we have a sizable number of organizations that would have implemented this goal. In addition, we have details of what is listed on the slide that should be included in the label, including the full name of the drug, the concentration and dose, not just the name, but the concentration and the dose, and the other details. Finally, there should be verbal and visual confirmation of all medications delivered to the sterile field with the above information as well. Now, having these labels, the recommendations for these labels not only can prevent wrong drug errors, but also set us up for the next recommendation under the quality process and risk management, which is implementing redundancy that support independent double check or automated verification process to detect and correct serious errors. You all know that in the perioperative and procedural areas is the only area in the acute care setting where a provider is responsible for selecting, preparing, and administering medications and solutions without any other additional double checking. So that's why we recommend these redundancy, and we recommend that technology vendor partner with anesthesia providers to incorporate workflow in the development of integrated machine readable coding and documentation systems. We know that we're not totally there yet, and hence we definitely needed our technology vendors to collaborate with us to make this happen. And using machine readable coding in the pre, intra, and post-operative procedural settings to verify patients, medications, and solutions prior to administration, and also implementing and integrating this machine readable coding to support real-time EHR documentation of medications and fluids. I know a lot of you is probably sitting there and going like, wow, this is a lofty goal. But if you are at all thinking that this is the right process, which I know you all know that this is the right way to do, because we know that barcode scanning of patient and medications prior to administration have eliminated a lot of medication errors. And hence, this is the setting where you need to be implementing these technology. And if you really seriously considering doing this, please go and talk to Dr. Nenji, who's sitting right here, because she definitely has been the pioneer in this work. Okay. And to introduce the next recommendation, I just wanted to present you with yet another case. And this is a resident who was starting a Mironone infusion in the OR, could not find the Mironone in the anesthesia mode on the pump, and proceeded to enter a drug concentration and infusion rate manually. The Mironone concentration was incorrectly entered as 200 micrograms in 100 ml instead of 20 in 100 because of misreading of the Mironone bag. And you can take a look at the bag on the right-hand side and see how it's easily misread. However, because just note that this misreading and misprogramming resulted in 100 times lower the concentration, which when the resident put in the intended dose rate of 0.25 micrograms per kilo per minute, the dose was 100 times higher than intended. Since the dose area reduction systems was not engaged, there was no alert to the resident for this erroneous low concentration. And by the way, just a side note, this vendor for this pump also have transitioned the hard stops to a soft stop in the anesthesia mode. And so someone can easily bypass that alert anyway, even when there's a catastrophic limit, just like this one that was entered. So the 100 ml bag of Mironone completely infused in a very short time, and that's when the resident realized that an error has been made. And because of that, the patient required observation and supportive care in an ICU, but did not suffer any serious adverse events. So hence, the medication under the medication delivery device acquisition, use, and monitoring, we recommend that smart infusion pump technology with dose error reduction systems be implemented. And I know a lot of you guys would say, yes, we already have that, but get this, we do want to make sure that you use that 95% of the time or greater. And the list of medications that we've included that should be included in this DUR system is continuous medication infusions, intermittent and secondary infusions, regional anesthesia infusions, patient control anesthesia, and IV hydration solutions. I know we can debate a lot about these IV hydration solutions, and we had some quite fun deliberation during our summit, but we ended up putting this recommendation in our guidelines because we have seen too many errors of free-flowing fluids that was occurring that smart infusion pumps can prevent. And hence, we're leaving that in our guidelines. And finally, we want to make sure that there's separate libraries for anesthesia that includes both the upper and lower heart limits for specific patient populations, because we are all human and fingering issue is common, and there has to be some limits that is catastrophic that will require a heart stop. And we also want to make sure that the limits include loading doses and boluses, and that there is audible clinical alarms to alert you about these limits being reached. And finally, implementing bidirectional interoperability with EHR. And that concludes my presentation. Thank you.